Thanks for attending this session this evening. Much appreciated. I know how busy you all are with all the new services and generally post-Easter, pre-Easter. So thank you for attending today, and also thanks to the LPC for organising this event, and also for their ongoing support with Core Mat. Today we're going to look at Core Mat that's been established in your area as a pilot site in both Peterborough and Cambridgeshire, and also what the initial evaluation has shown and how we're going to take this service forward over the next year. Myself, I'm Kulvinder, so I am a medicine management pharmacist within the pharmacy team at CGL, working under the Director of Pharmacy, who is Mohammed Faisal. Some of you might know and some of you might not. Previously, in my role, I've been a pharmacist for more years than I like to think. And within that, I've worked in community pharmacy, worked at GP practice level, and I came into substance misuse approximately 10 years ago, and I've been a prescriber ever since. So also run clinics as well at the same time. So today, the agenda we're going to be looking at is, oh, by the way, also welcome to Lisa and Emma, who you all probably know are our community pharmacy liaison leads for both Peterborough and Cambridgeshire, respectively. So today's agenda we're going to look at is why we made the change to Core Mat. I know it's been in place for you guys for a year now, but obviously we didn't have a meeting like this when we launched the service first. So it's also just looking at some of the background behind why we made the changes. Looking at the aims and components of the Core Mat, wellbeing support, the missed and late dose notifications, the supervision of monthly claims, the annual pharmacist review, looking at the activity fees and payment structure, and also some training and insurance background, and giving you an opportunity for question and feedback at the end. Have the next slide, please, Karen. So why did we change? The standard supervised consumption model has been around for many years, and it hasn't changed in that time. Supervised consumption, what we're doing today, is pretty much what it was when I first became a pharmacist. And the scope for equity for all service users was not there. So approximately 70% of our service users across CGL are not on a supervised dose. And although as pharmacists, we are aware that there are daily interventions going on in community pharmacies to support all service users, there was no way of recompensing or remunerating pharmacists for that support that you provide on a regular basis for those service users that are not on a supervised dose. And again, the support that you offer was not measurable as such. And the scheme can be considered to be transactional in that we know that at a given time for a supervised service user, a particular dose is administered and a particular day. And that is essentially the limitations of the previous supervised consumption model. So we wanted to improve the quality of the information we receive, and also the efficiency of the way we receive that information. And also within that, to improve service user safety and care, and monitor their adherence with their treatment plan with a non-CGL health professional. And at the same time, we were aware that our remuneration and engagement with community pharmacy was lacking within the old supervised consumption model. And most of our services are reliant on a prescription generation model. So it's essential that we have that good working relationship with our community pharmacy colleagues. And we're aware as an organisation of the stresses that community pharmacy is under at the moment. And we're trying to support as best as we can to help you deliver these services. And strategically, within an organisation, we're aware of it, but also OHID, the Office of Health Inequalities, are also aware of it. And there's collective work with other substance misuse providers to see how we can improve the relationship and the workings within community pharmacy for our service users and yourselves at the same time. There was some recent updated guidance, I don't know if anybody's seen it, regarding community pharmacy and delivering substance misuse services provided by OHID. So it's worth having a look at that, because it gives an idea of where OHID are coming with their strategy for community pharmacy-based services for substance misuse. So the new service was developed over a year or so with LPCs and commissioners within each area that we actually launched a service in. Can I have the next slide, please? So CoreMat aims and components is to provide a holistic approach to enhance the health and well-being of individuals affected by drugs, manage the risks such as drug-related deaths, overdose, and other threats to health, and using a quality-driven service within a framework which underpins it and standardized approach across those services that are operating CoreMat through community pharmacies. So we have a standard approach across all of our organisation. The first and primary concern was the wellbeing support that community pharmacies offer. And then you've got the missed and late dose notifications. We've got the supervised consumption component, and then the annual review by the pharmacist. As I say, the scope of the service was to provide equity to all service users and improve the quality and efficiency of the service, enhance safety of service users through the missed and late dose notifications, and also offer service user engagement with a non-CGL health professional in the way of a pharmacist through community pharmacy to help engage service users with their relationship with the pharmacist, and also to help them engage with their treatment plan. And we all know that there's some things that service users will tell us, and by far we find that community pharmacies get more information, and service users are more open to offering that information to pharmacists than they probably would be to us. So by you doing the pharmacist-based review, we can gain a lot more information to help safeguard service users in the end of the day. The reason why you probably think is why we don't get the full information is because obviously there is always that restrictive thought in service users' head that if they do disclose something, they might be punished in some way or the other, for example, with a change in their prescription or a increased collection or switch to supervised consumption. So they do sometimes hold things back. We do know, because obviously through regular testing and through feedback that we get from, for example, sometimes family members will disclose. We do have an awareness, but it's just getting that extra information and also help build that relationship that you have with your service users as well. Obviously, within that, there was also the need to improve pharmacy remuneration and engagement with substance misuse services operated on our behalf through community pharmacies, and generally to improve the health and well-being of our service users. Can I have the next slide, please? So we ran an evaluation after 6 months, and that has been shared with OHID. It's been shared within our organisation, and it's been shared with your LPC leads. And obviously, we're doing these meetings across the 6 original pilot sites, so we can feedback what we gained from the initial 6-month evaluation with all contractors as well. So the service was launched across 6 pilot sites. So that was Cambridgeshire, Peterborough, Norfolk, East and West Sussex, and West Kent. We've since had a launch of this new service in 3 new areas, 2 in Lancashire and 1 across all of Hertfordshire. So they've joined the pilots as well. So the original 6 pilot sites covered approximately 5,000 service users, I should say. And that was 15% of our service users, but 5% of all service users in structured treatment across England, even outside of CGL. We utilised 540 pharmacies. And the initial results that we had was we managed to retain all pharmacies that were engaged with previous supervised consumption. We also had an increase of 5% for new pharmacies wanting to participate in CoreMat. With the equity of service users having that pharmacy-based intervention, we had the opportunity for an extra 3,600 service users to have the opportunity for a pharmacy-based intervention. There were 1,200 odd service users within that 5,000 cohort that were currently on supervised consumption. And there were over 5,000 that were in part of the service. So we had an extra 3,000 plus that were offered this service through community pharmacies. The average CGL monthly spend increased from 6,000 to 10,000 for our individual services on an average. And for yourselves, looking at Cambridgeshire, the average monthly spend for our CGL service on this particular core mat service increased from 9,000 of the supervised consumption scheme to 13,000. And for Peterborough, it went from £6,000 to £11,000. So there was a significant uplift in payments being made to pharmacies. We found that there was a reduced time spent by pharmacists contacting services via phones, and there was a single point of contact via farm outcomes. There was a 50% reduction in processing of missed and late dose notifications within the admin teams within CGL, and we undertook, or you undertook, over 1,000 pharmacist-based reviews across the pilot sites. The general uplift across average spend was 66%. And for the first time, we had a standard method of reporting across all 6 pilot sites. So for us, that was quite important, so we could see the benefit of a standardized approach, because previously we had different services. Some were reporting by email, some were reporting by phone, some had different phone numbers. Some pharmacies complained that phones weren't attended to unless they had a dedicated phone. So within all of that, it's improved the general relationship between community pharmacies and services, as well as increasing the information that we're getting to safeguard service users. Can I have next slide, please? So in terms of pharmacy engagement, we started off with 515 pharmacies across the 6 pilot sites, and we increased that to 540. So that's an increase of 25 pharmacies, which may not sound a lot, but given the changes in community pharmacy at the moment that we're experiencing, we had a net increase of 5%. So that was a good result for us. And also it highlighted to quite a few pharmacies that the value of being on the scheme, and also the benefits of engaging with more service users within this particular scheme as opposed to the previous supervised consumption scheme. For example, because you're getting the monthly payment for each service user that's registered with the pharmacy. Next slide, please. So we're now going to look at the individual components within the core mat. Obviously, you guys have already been delivering it, so it's just more of a reminder. So the wellbeing support is provided by any appropriate trained member of staff within the service. And it's at the request of a service user. And it includes things like harm minimization, healthy living advice, signposting, referral, safeguarding. Obviously, some of these things you already do as part of your contract, particularly the last 3. And healthy living advice. And around the harm minimization advice, looking at things like safe injecting, looking at overdose prevention, BBV testing and awareness, safe storage of medication, alcohol awareness, smoking cessation, any of those. And if there's any particular item within the harm minimization sphere or specific to substance misuse that you feel your staff are not upskilled to offer, please let us know. Please let the services know, because we can provide that advice and that training, so we can upskill your staff as well. I know we do get some resistance from staff within pharmacies on things like safe injecting. It's pretty basic advice that we would ask, just not to share any sharps or any equipment with anybody else, and to use clean ones each time, and to dispose of sharps equipment safely in the bins provided. Next slide, please, Karen. So looking at missed and late dose notifications, obviously our treatment plans that we offer service users are based on risk. The biggest thing for us is safeguarding service users and managing the risks that they have on a daily basis. So treatment plans can change very, very frequently and at a very short notice. And missed and late dose notifications highlight for us any adherence concerns, and they also alert us to proactively engage with service users. And also they support people like me as a prescriber, so that we know that our treatment plans are accurate and reflect what is happening in the current situation with the service user. So obviously, prior to core mat, I know there was reporting of missed and late dose notifications across Cambridgeshire and Peterborough, but the reporting was quite low. So the information that we got wasn't enough to form a good opinion on what's going on with the service user. So it also helps us to enhance the service user's adherence to the medication, and also any risk of disengagement. And obviously, if they disengage from their treatment, the risk is that then they'll use illicit drugs, and after being on a period of methadone or buprenorphine, Esprinor, the risk of loss of tolerance and using illicit drugs increases the risk of overdose. So for us, it provides a standardized approach across CGL service on how we report missed and late dose notifications. And also it's been highlighted previously, both with coroners and by OHID, that the lack of communication between community pharmacies and commissioned services when it comes to lack of adherence or missed collections can result in death. And the need and the stress is on the two sides working together at all times. And obviously, within missed and late dose notifications, it is a risk. So if you know that a service user is not collecting their medication, that is a risk that you know about within community pharmacy. That is best to be shared with the providers of the service to then safeguard the service user and also safeguard your risks as well at the same time. Obviously, the World Health Organization estimates that there's 50% adherence to medication. And for us, within the realm of substance misuse, it takes on the added risk, as I say, because if a service user is not taking their prescribed medication, they will be using illicit. And then with illicit, we don't know what they're using. We don't know the purity of what they're using. And obviously, at the moment, there is a projected heroin drought from September this year because of the reduced production in Afghanistan, which is our main source of heroin in this country. And also, we've now got the new synthetic opioids, which are a completely unknown risk because we don't even know what they're using. There's different ones coming around. For example, we've got nitazines at the moment, which are approximately at the moment, from the guesses and from the basic screens we've got, over 100 times more potent than heroin itself. So the risk that poses to a service user is immense. And so for us, we want to intervene as soon as possible when we get these reports of missed or late doses, so we can engage and increase our contact with the service user to reduce the risk of them coming off prescription and using illicit drugs at all times. Within this scheme, the envisaged end result is, at the moment, when you report on farm outcomes, we get an automatic notification drop into our into our service emails, into our secure emails, and then we can upload that to the service user record, and also the key worker will then engage with the service user. The end game, which is in final stages of testing, is that when you actually report a missed or late dose notification, it automatically sends a text message out to the service user. It would just be a basic text and say, we are aware that you have missed a dose or collected a dose late, and it will have our contact details, but also at the same time, we will be engaging with the service user as well. So it's just to make the service user aware that we know where they are within their treatment plan, and any intervention that we need to do to help prevent them coming off prescription. Can I have the next slide, please? So just a quick review of the missed and late dose notifications templates on farm outcomes. So it would just be entering the date that the dose was either missed, and then also entering the date the actual late dose was collected, selecting the drug, and then the subtype, and then the reason for the collection, whether it's a missed collection or whether it's a late collection, and any notes that you want to add if there's any safeguarding issues or anything else that comes to mind. Can I have the next slide, please? So in terms of our results from the 6-month evaluation, this particular component of the core map has produced some real great results for us. The number of pharmacies engaged and reporting missed dose notification increased from 87 to 163 across the 6 pilot sites. We had an average increase of reports across the 4 services, which was Norfolk, Cambridgeshire, Peterborough, and West Kent of 475 to 800%. For Cambridgeshire, the number of missed dose notifications was on average 673 per month, and Peterborough was 613 reports per month. And there were 43 pharmacies engaged out of 84 in Cambridgeshire and 20 out of 32 across Peterborough. So that was an increase as well. The increase for you guys was around about the 475% mark. The 20% increase was seen across East and West Sussex, where they had a very organised system of missed and late dose notifications prior on the old supervised consumption scheme. But generally, across all our service, the reporting of missed and late dose notification increased significantly. And for the first time, it gives us the opportunity to know about non-supervised service users that are not engaging with their treatment. And also, we've got the same direct farm outcomes platform for reporting of all missed and late dose notifications. Again, I'd encourage everybody to report missed and late dose notifications. Obviously, there is a gap between those that are engaged with CORMAT and those that are currently actively reporting. So if you can, please report all missed and late dose notifications within the 1 working day, as per the SLA. And again, thank you for all your efforts with this particular component. And this has helped us a lot because we have actively engaged with service users across the 6 pilot sites. And we're getting some quite good information as to why service users are not engaging. We can also look at what the difference is between, for example, methadone and buprenorphine. And we're finding that methadone is less adhered to than buprenorphine. And for us, for those services that are offering like the Buvidal monthly injection, it's something that we can then target for certain service users across service. So it's just helping us to encourage service users to maintain their treatment plan. Can I have the next slide, please? So supervised and non-supervised consumption component. Obviously, supervised consumption remains the core of the scheme. It is the foundation. And we've also changed the SLA this year to allow for any trained and competent member of the dispensing team. So looking at the skill mix within pharmacies, it's to encourage you to assess who you feel is competent within your dispensary team. It doesn't necessarily have to be the registered pharmacist or a registered technician. It can be any member of team that you have assessed. And that assessment is down to you guys. As long as all we ask is that the member that is participating in the scheme is aware of the SLA, is aware of the pharmacy SOP for supervised consumption, and knows when to refer to the pharmacist at any stage. We made it a simplified single data entry per service user per month on farm outcomes, and we took away the need for daily entries for supervised consumption. Obviously, it does require the registration of all service users that are supervised and non-supervised to allow for the monthly activity fee to be paid. Can I have the next slide, please? So just a quick look at the registration. I'm sure you guys all know. And can I have the next slide as well, please, Karen? So what we request is that when you're registering a service user to use the PDS file. The reason why we ask for this is the PDS file is linked to the NHS records, and also our client records are also built up from the NHS records. So, for example, if you incorrectly spell somebody's name or give them a nickname, when it comes to linking with farm outcomes and then dropping into our patient medication system and patient record system, it will throw up as an anomaly. It won't link up with somebody directly because the NHS number might be different or the NHS number might be missing. So this is where we ask if you can to use the PDS at all stages when you register a service user. Can I have the next slide, please? And just a basic review of the monthly supervised and supervised dispensing. So it is just the service user's name, the medicines they're taking, whether they're supervised, and then you'll have the notification about, did you notify us of all missed or late collections? And if you click no, there will come up a warning, which will be on the next slide. And it's selecting the drug that was supervised and the number of doses that were supervised. And then the last stage is the declaration that you dispense for 10 days worth of medication to this service user, because that triggers off the monthly activity fee for all service users that are with you and registered with you, whether they're supervised or whether they're not supervised. So can I have the next slide, please? Thank you. This is just some of the highlights of the template for supervised and non-supervised. So obviously, if it's supervision that you ticked, it will be the number of supervisions per service user for that particular month. The missed and late dose notification, if you tick no, it will come up with a message that missed and late doses, please ensure you report all of these for the month. What we do find sometimes is some pharmacies do not report the daily missed and late dose collections, and what they will do is they'll report them when they do the end of the month. It's fine, it's given us some information, but it doesn't allow us to actively engage on a daily basis. Obviously, if we get a report of missed and late dose collections at the end of the month, we've got the whole month where we've missed actively intervening to safeguard the services. So if we can, please make sure you do the missed and late dose within the 1 working day. And obviously the last one is the 10 or more day declaration for the monthly activity fee. Next slide, please, Karen. So in the original core MAT for the pilot, we asked you to undertake quarterly MAT reviews. So you completed just short of 1,100 across the 6 pilot sites. So it worked out to 20% of all service users. And it was lower than what we expected, but then we were aware, obviously, with the current constraints within community pharmacy, that it might not have been an achievable target. But we put the target there just to see how well we can get to adherence on that. And the pharmacist reviews that were done we did get some real good results as to concerns service users were expressing to the pharmacist, which we as a service were not aware about. So 16% of service users reported adherence concerns to their MAT medication. And that was where we actually actively engaged them with the service user when we got these pharmacist reviews come through, to actively participate and engage with the service user to see what the issue was. And the majority of the time, the issue was the dose was not holding. So it was, as I said, as the next comment makes, 12% of service users were on a suboptimal dose and continuing to use illicit drugs. So the aim of our treatment is we don't go by dose. So we will prescribe to whatever dose is needed to control the cravings for opioids and also manage the withdrawals for opioids. So with the aim of treatment is to have zero use of heroin or any of the opioids, and specifically maintained on their buprenorphine or methadone. On 109 occasions, naloxone was offered or a referral made, which is crucial at the moment with the new synthetic opioids and the amount of overdoses that we are seeing at the moment, and the risk that it's putting to service users, where service users are saying that they will take a drug which is sold as heroin, but it's actually nitazene based, and they cannot remember anything from the moment of them using the drug to when they came around. And some people are taking over 24 hours to come round from that particular drug, and we have had deaths across the country because of this. And it was very good to see pharmacists offering healthy living advice, such as smoking cessation, diet, exercise, but also referring to mental health and also referring to GPs for physical health concerns that service users were reporting. And that's not something that we would be doing on a regular basis, because we would see a service user between 3-6 months, depending on how stable they are. So that sort of practical advice is often given by our recovery coordinators, who will liaise with the GPs and liaise with mental health. But this way we're getting a double-pronged effect if pharmacists are doing it at the same time. And within making every contact count, different voices, different relationships. So as I say, what we get told by service users can sometimes be different to what they'll be open to telling you about as well. So it's just getting that extra information and safeguarding them at all times. So from that, we decided that, and with discussions with the LPC, we decided that we're going to move to an annual pharmacist review. So the annual pharmacist review can be done at any time from the new contracts start on April the 1st this year. So from April to following March 25, every service user, whether supervised or not supervised, can be offered an annual pharmacist review. And that'll be looking at adherence to their MAT medication and any issues raised. But also we introduced now adherence to their other medication, whether prescribed or taken OTC, and any issues raised. Highlighting any possible contraindications or drug interactions, and reviewing their safe storage of the MAT and naloxone availability, and also providing healthy life intervention like that as it was in the previous quarterly MAT review. Can I have the next slide, please? So within that, I'm just going to look at the annual pharmacist review and how it looks on the pharma outcomes template. So it would be reliant on consent as the previous quarterly MAT review was. So if a service user does not consent to the annual review or does not consent to it being shared by the pharmacy to CGL, then you can end the review at that stage. If service user does consent, and then we will ask for consent to review the summary care record for yourself, so it helps you doing the actual review, so you can get a current up-to-date list of their current medication. Obviously, if the service user declines that, it's not a reason to end the annual pharmacy review, but you can just ask the additional information to help you with the review. And we then look at things like allergies and adverse drug reactions. So if there's any allergic drug allergies generally, please document those. If there's any adverse drug reactions that have had in the past, please document those. Can I have the next slide, please? So similar to the previous quarterly MAT review, it will be looking at their current MAT prescribed medication, and it will be a drop-down menu. And so from the menu, you can just select the drug that they're currently taking and then manually enter the dose and discuss any adherence issues that they have. And also look at any patterns that they've got to any missed doses, or also documenting how many doses have been missed in the last 28 days, and discussing with the service user, are there any concerns or are there any hindrances to them taking their medication regularly, and any support they would like with improving their adherence. That's interventions that you would like us to do as opposed to what you could do, because the limitations within the community pharmacy sphere. So it's just what the service user suggests that we could help them with. And then the next stage is similar to the previous quarterly MAT review, looking at the optimal MAT dosing. So optimal MAT dosing that we aim for is between 60 and 120 milligrams of methadone and 12 to 16 milligrams of buprenorphine oral, whether that's Espranol or sublingual. And just to check if they're on an optimal dose. And also, if they're not on optimal dose, then to check if they're using any drugs on top. If they are not using any drugs on top, it's just checking whether they're on a suboptimal dose and drug-free, or they're on actual agreed reducing dose. And also then the opportunity for them to discuss any issues regarding their MAT medication and their dosing. Next slide, please. The new component that we introduced is similar to an MUR. It's just to give us that extra information, because sometimes when a service user turns up with us for a review, they don't have the full picture of what their medication is. And we don't always have access to summary care records as efficiently as you do. So our summary care records, we have a team, and it takes a couple of days for summary care records to come. So when it comes to a medication review with a prescriber within CGL, we don't always have this information. So it's very useful for us to have this information. And service users are not sometimes the best at remembering what medication they're taking. And particularly when it comes to, for example, COPDs or mental health medication, it's good for us to have that accurate picture. So it will be typing in the medication and what they're currently taking. And once you start typing the first few letters of the medication, a drop-down list will appear. Recording the dose that they're taking, looking at the service user understands the medication that they're taking, why they're taking, and whether they're adherent, and making any comments that the service user might discuss at that point. And this applies to both prescribed and OTC medication. And when you come to the end of those questions, it will come to the point where it says second medicine to be recorded. If a service user is on another medication, you repeat the process again until we go through all the medications. We then ask you to look at if there are any contraindications with the current medication that they're taking. And also looking at any interactions that you feel that are worth noting with their medication, whether that's prescribed by CGL or their general medication that they are taking. And for that, think of issues around opioid stewardship, for example. So if service users are prescribed a MAT from us, but then also taking an opioid from their GP, whether that's cocodamol, or whether they're buying OTC opioids over the counter, such as cocodamol, solpadeine, etc., making a note of that. Sometimes the SSRIs, antidepressants, or some of the antipsychotics can prolong the QTC interval, so that can affect methadone in particular. And you've got things like if people are co-prescribed benzodiazepines by their GP, and then they're taking MAT medication from us, they all add up as depressants, so the risk of respiratory depression is there. And also you've got the things like the pregabalins and the gabapentins that can increase the risks as well. So it's just making some general comments about those. Have the next slide, please. So like the previous quarterly MAT review, we're asking you to review with the services that they've got an naloxone kit. If you are part of an naloxone SLA, then if they haven't got a kit, please provide one and submit your claims. If they're not part of, if you're not part of the naloxone SLA, then please refer on to either another pharmacy that is, or refer to CGL services so we can provide one, and just documenting that. We've added the component with regards to safe storage as well, just to make sure all our service users have a safe storage box. So if you don't know what these are, these are locked wooden boxes with a padlock. So it safeguards children in particular, because there have been numerous reports of poisoning and death with methadone, with children that are in contact with service users that are prescribed MAT medication, more so with methadone than with buprenorphine, because it's a safer drug. So we always make sure that every single service user has a safe storage kit with them. And if they don't have, please refer to us. So tick yes that you've done the referral. Next slide, please. And the last stage is the healthy living advice, similar to the current quarterly MAT review. We ask you to offer any healthy living advice that the service user would like, and also document if you've made any relevant pharmacy service interventions or signposted to any additional services, and document those as well. And then the last stage is for the service user to ask any questions that they would like to ask yourselves on any sphere that they think they need to ask you for. So it's just being a bit more holistic than what the previous one was. Obviously, the previous one, because we were asking you to do it quarterly, it was limited information, and it will be done repeatedly throughout the year. So with the annual review, the aim is to get a more detailed discussion with the service user on their current health needs, and their current medication and treatments that they are with. And with the quarterly MAT reviews across Cambridgeshire, we did 306 in the 6-month valuation, and in Peterborough we did 197. In terms of reporting, there was on average between 1 to 7 pharmacies that had completed a MAT review across the area, so the uptake was quite low. And we're hoping that with this annual pharmacist review, you can do this spread out throughout the year for all your service users. So we do expect to see an increase in reporting when it comes to the annual pharmacist review. Next slide, please. So just looking at the fee structure, so we have kept the supervised consumption rates exactly the same. We've introduced a individual specific payment for each quarterly MAT review that's completed of £30, and then the monthly activity fee for all service users is £7.50. So per service user, there is no change, there's no loss at all. So what we've done is we've specifically given a payment for a completed annual MAT review to help increase the uptake of that service. So all service users can benefit from a pharmacy-based review. Next slide, please. So training and assurance, for registered pharmacists and technicians within the pharmacy, we still expect the CPP training and declaration of competence to be made. The dispensing team competence and the members of the team that are going to be doing the supervised consumption, as I say, that's delegated now to you guys within your pharmacy and within your skill mix within the pharmacy and dispensing team. who can undertake the task of supervised consumption, like I said, as long as they are aware of their current SOP and SLA. We will be providing annual training for the pharmacy team, so this counts as one of those. So you can, once this is recorded and uploaded, you can share with your teams. But also with our CPLLs will be doing pharmacy events annually going forward, just to upskill and train all members of your pharmacy team. And it's open to all members of the pharmacy team on any topic. So if there's anything in particular, like I say, please let our CGL services know. We can tailor the training to that particular component of what you would like. There'll also be now an annual audit of the service based on the SLAs. So each pharmacy will be visited in an annual short audit. It wouldn't take more than 10 minutes. It's some basic questions, like I say, based on the terms of the SLA, and to ensure we've got engagement with the SLA. And also on a monthly basis going forward, we will be monitoring the data and liaising with the LPC to promote the service and all components of the service within pharmacies across Cambridgeshire and Peterborough. As I say, we are putting considerable investment from CGL with the service, so we're looking at this going forward as a platform to launch other services. And also across the country, we're the first substance misuse provider that's doing a service like this, which is more holistic. So there are other services that are looking at this as well. And we have been approached by commissioners outside of CGL commission services to look at how they can implement this sort of service within their community pharmacies across the country. Next slide, please. So this is just some feedback that we've had from the 6-month evaluation from all members involved, from pharmacy service users, services, CGL services, and LPCs. And that is the end of my presentation. Now it's open to you guys for any questions.
Feel free to put your questions in the chat if you prefer, if you don't want to put your hand up and ask them on camera.
Flabbergasted you all.
I'll just give people a moment in case anybody's frantically typing away with their questions. I know a few people joined halfway through the presentation, so just to let you know, we will be sharing the recording and the slides in our update next week. So don't worry, you can catch up.
Hi, can anyone hear me?
Yes, we can hear you.
Yeah, hi, my name is Tian. I'm from Petersfield Pharmacy in Cambridge. So just a question in terms of the annual pharmacist review. So when can we start offering the review to the patient?
On the 1st of April.
Oh, all right. Okay. So does it matter, like we just finished the last quarter of the first year after the other year? Does it matter if we start now?
No, you can start now. Yeah, by all means. It's a new financial year. It's a new year of the SLA, so please go ahead.
Okay. Does it matter if the patient is a new patient with us, or does it matter there has to be a regular patient with our pharmacy?
No, once a service user is engaged with you on a prescription, then you're free to offer the review. Obviously, within that, we appreciate that there may be some case where, for example, a service user leaves your pharmacy and goes to another pharmacy, and that's within the scope. That's fine.
All right. Okay. Thanks a lot. Thank you.
Rita, go ahead.
Thanks. I was just going to ask that question. What if someone leaves one pharmacy and goes to another? But you've answered that, so that's fine.
Yeah.
The question is, sometimes when you do a review, and I remember this with MURs quite a lot, is that sometimes there's something that's raised and you almost want to review it in a few months' time. And with this particular client group, I can imagine that happening more often. And it may be due to the methadone or buprenorphine, but it may be there are other drugs, there are other health issues. So is there any option for that? with
There's
this?
not a review component as such, because we obviously as health professionals, as pharmacists, obviously within our ethics and practice, it would be down to us to follow up as we would generally with any other service user, any other patient sort of thing, as such sort of thing. So there isn't a component to follow up. Obviously, if it's something that involves us within CGL, then that's for us to follow up.
Okay. Or we could say, do you know what? I discussed subject X. It could be them wanting to stop smoking, or having their blood pressure checked. It could be anything. And then we could, I suppose, ask CGL support worker to follow up.
That's fine. That will come through to us. So once you do the review, that drops into our generic secure email, and then that will get followed up with the service users records. Obviously, if it's, for example, the blood pressure was high when they came in today, you just had to do a blood pressure check and the blood pressure was high, then that would be obviously be a referral to the GP.
Absolutely. But often it's not those things, it's where you've given advice and said, if you do this, X will happen. And then a few months later, you want to just make sure that that did happen, or those actions were taken, or that you might want to follow up and take the next step. But that's fine. Thank you.
There's a question from Geeta in the chat. She wants to know if there's any ideas on how to engage remotely, so with delivery patients, etc.
Is that in terms of doing the annual review?
Yes, I would assume so. Unless you want to correct me, Geeta. So yeah, I guess it's with the annual review.
I mean, we haven't put a scope of limitations of doing the review, whether it's face to face or whether it's remotely. So I don't have a problem with it being done remotely.
Anna?
Hi, Corinda.
Hello.
My question was going to be regarding naloxone. So how often would you feel a pharmacy should be supplying naloxone to one of your users? Because I've heard lots of different things on this.
So in terms of naloxone, we ask you just to ensure that our aim is to have every service user with a naloxone kit, or a member of their family to have a naloxone kit, or somebody that is involved in their care to have a naloxone kit. That is the scope of offering naloxone that the government advises. We promote naloxone. So if a service user's naloxone is out of date, it's lost, they can't find it, it's left at somebody else's house, it's a trigger point to offer a new one.
So should you be asking every 2 weeks when they come in? Do they have a naloxone pen or something?
It's up to you guys. I mean, generally, I think we've got 90% of service users reporting to have a naloxone kit for service users that are engaged with us. So within that, it would just be a reminder to every service user that have you got a kit. It's up to you how you remind them, and the essence is to capture those that are saying they haven't got one.
Okay, thank you.
No worries.
Another question in the chat from Regina. She says, after doing the first review, will farm outcomes remind us in a year's time that the next one is due, or will it be up to the pharmacy to remember by putting an entry in the PMR?
Yeah, unfortunately, farm outcomes is a data collection point, so it doesn't do anything like reminders. So what we've said in the manual, so the manual that accompanies the core mat has been updated, and our community pharmacy colleagues, liaison lead colleagues, Emma, David, and Lisa will forward on the manual to you guys. But yeah, we encourage you to put a reminder onto the PMR, or to put an entry on the PMR that a annual review was done on this particular day.
Last call for questions then. If not, you can all have 9 minutes of your evening back. Okay. No, I think that's it. Thank you very much, Corinda, for giving up your time, and Lisa and Emma as well. Great to see you. Thank you for all the pharmacies that have turned up. As I said earlier, we'll share the recording and the slides in our update next week. And obviously, if you've got any questions, talk to us at the LPC, or to your liaisons at CGL. Thank you very much, everybody. Good evening.
Cheers all. Thank you.